Okay, thank you, Dr. Sharath and Dr. Ashari for having me in this IC. So, intraocular foreign body endophthalmitis. It's an emergency. Now, the endophthalmitis in open globe injuries, as far as they are concerned, there are some factors which are increasing the risk. For example, when you see a open globe injury, so this is a situation where you have to be worried about endophthalmitis. One is a retained intraocular foreign body. Then, second is a delay in the wound closure of more than 24 hours. So there is a fourfold increase in such a case of endophthalmitis when the delay is more than 24 hours. Now, injury in a rural setting, you know that here, of course, there is increased chance of endophthalmitis because there is increased risk of soil contamination, risk of a fungal endophthalmitis, things like that. A ruptured lens capsule is another risk factor because that the disruption of the crystalline lens it gives easy access to the organisms to the vitreous cavity, and also the lens matter sort of serves as a providing increased nutrition for the growth of these organisms. So whenever these factors come together in an open globe injury, you should always consider it prudent to start prophylactic antibiotics, especially consider prophylactic intravitreal antibiotics like an intravitreal vancomycin 1 milligram in 0.1 ml and ceftazidime, the usual combination. And fungal coverage with amphotericin B or voriconazole can be added in patients with appropriate history. Of course, systemic broad spectrum antibiotics is something which we all will start, but the intravitreal antibiotics, many people we are sometimes hesitant, but when these things comes together, we should definitely do that. So this was a case which was referred. This patient had this was a referred case. He had a ruptured lens which was removed. CT scan showed the intraocular foreign body. He was given intravitreal antibiotics and then referred. That is exactly the correct way to refer a patient. And correctly also, and no intraocular lens was put because it needs, you have to deal with intraocular foreign body, and it is for the post-segment surgeon to actually decide whether he wants to take out the intraocular foreign body through the pars plana route or whether it has to come out through the anti route itself. So it's better to not put an IO in this case. Now, endophthalmitis following open globe injuries, there are a few dilemmas like whether you should go for a primary vitrectomy plus intravitreal antibiotics or a vitreous biopsy and intravitreals, whether you should go for a complete versus limited vitrectomy, whether to use silicone oil or not, etc. But as far as these scenarios, so when you have an open globe injury with this scenario, there is no confusion at all. These are when there is an intraocular foreign body, when there is a retinal detachment, when there is a suspected fungal or a virulent bacterial organism like Bacillus cereus. No confusion here. You need to go in with a urgent primary vitrectomy with intravitreal antibiotics at the end. So when you have a situation like this, pars plana vitrectomy with intravitreal antibiotics is the mainstay of treatment. And if you don't have a situation where you cannot actually directly intervene and you are planning a referral, then you should refer after giving one dose of intravitreal antibiotics, a combination of Cefta and Vanco, and taking a vitreous tap and sending it for the culture. Systemic broad spectrum antibiotics, of course, these are the options, vancomycin and ceftazidime. Then alternate is amoxifloxacillin or any other fluoroquinolone. Then addition of clindamycin 300 mg every 8 hours and amikacin or gentamicin should be considered in severe suspicious cases of bacillus. That's the history of IOFB, as we already told, or anaerobic bacteria. And systemic fluconazole or voriconazole is recommended intravenously for fungal infections. Then topical antibiotics, and of course you should consider amphotericin or voriconazole intravitreal injection if a vegetable matter contamination is suspected. Intravitreal steroids we generally withhold, especially if a fungal organism is suspected. Now, Bacillus cereus is an organism we need to consider in these situations, especially when you have got an intraocular foreign body inside, especially when you have got an injury in a rural setting, etc. Now, here the endophthalmy will be a rapid and fulminant onset, and you need to actually intervene immediately by a complete vitrectomy. And the presence of an intraocular foreign body significantly increases the risk of this particular type of endophthalmitis. So this is one case which was referred as an intraocular foreign body with endophthalmitis. Already 2 intravitreals has been given. As you can see that, here the intravitreal antibody is sort of acting and is the infection is sort of under control. You can see that it is organizing. So this was taken up for vitrectomy, and the lens is also cataractous. So initial step was to actually remove the lens, and then we had to go in with the pulse plana vitrectomy. It's a relatively old case. So you can see that the vitreous cavity is full of exudates, and that is being cleared. So nowadays we generally go for a complete vitrectomy whenever possible. Previously it was core vitrectomy, but now with the better chance of instrumentation and all, we generally go for a complete vitrectomy. Now you can see that intraocular foreign body with a few exudates lying on the retina. Now the retina is really friable, and the presence of this large intraocular magnet in our armamentarium actually helps us to remove it very automatically. We don't have to actually go in. So the situation where we could sort of preferentially use this sort of a magnet. So now the IOFB is out, and now we complete the procedure by giving intravitreal injections again. So follow-up is important, especially even if you do a primary vitrectomy, even if you give a intravitreal antibiotic, the follow-up is very, very important. So if there is no improvement is seen in about 48 to 72 hours, a repeat intravitreal antibiotic injection has to be considered, or even a repeat re-vitrectomy also has to be considered. So follow-up is important. How the patient responds and how you intervene is very important. Now, secondary procedures is generally required, because the initial, these sort of patients, generally go in for a lot of complications like retinal detachment, then proliferative vitreoretinopathy, vitreous hemorrhage, choroidal detachment, cataracts. So all those things has to be managed in the follow-up procedures. Corneal opacification again will be there. So these are all for the secondary procedures. This was another interesting case. This patient was actually brought with a history of a repaired scleral wound after 2 weeks, because of the presence of some of those yellowish exudates that you can see in the inferior vitreous cavity. So what is this? Whether this is a sort of a chronic endophthalmitis or a sterile sort of an inflammation, what exactly it was. So, but then closer examination actually found, we found this. So this was in the anterior part of the anterior vitreous. There was something elongated like that. So suspicious of a foreign body. Now, B scan also sort of confirmed that it was a foreign body. The thing was that the previous records, it was we could actually see the CT scan, B scan, everything was done. But the thing was that it was missed. Because when a foreign body is there and when it is missed with a CT scan, now it obviously means that it is not a metal foreign body. It has to be something like an organic foreign body, like a wooden splinter or something like that. So we thought that maybe it is a wooden splinter, even though, because further questioning also revealed that the patient was indeed working on wood, and there might have been a splinter flying off, which he sort of forgot to tell us. So we sort of went in. So this was the case. So you can see that this is after vitrectomy. After vitrectomy, you could actually see that that foreign body there, and we just sort of got some forceps and removed that. And in between there was some small problem, because the patient woke up. He was just sleeping, and he woke up in between, and we had a slight retinal injury. So this is what is this is the patient's own eyelashes. So that was what was actually causing all these problems now. So eyelashes is known to cause this sort of an organic inflammation and a granulomatous inflammation. Okay. Organic foreign bodies such as animal hairs, insect parts, thorn and vegetable matter are contaminated, and they are known to cause fulminant endophthalmitis. So other presentation in such cases would be delayed granulomatous inflammation, then recurrent endophthalmitis like this. So in this case, probably it was not an endophthalmitis, as it could be a granulomatous inflammation, but could not be sure whether it's a chronic endophthalmitis also. So we just ended up giving an intravitreal antibiotics also. The patient did really well. He could actually regain full vision after that. So you need to be sometimes concerned about these sort of foreign bodies. Even if you sometimes miss these things in the initial CT scan, you always, and when the patient comes back with a history like this, you need to be thinking of this. And there is a description of a case in the literature where an intraocular eyelash caused a recurrent endophthalmitis and were not found by routine examination. And this was actually identified during the vitrectomy when they did the vitrectomy for the endophthalmitis. So this is something which you need to know. So to conclude, open globe injury with intraocular foreign body, a prompt removal of the IOF and initiation of empirical broad spectrum intraocular antibiotics is the single most crucial step. So IOF P plus endophthalmitis, prompt vitrectomy with intravitreal antibiotics will be end. Thank you.
So one question, in the presence of sidrosis, does it alter your management of the intraocular foreign body? How would you?
Yeah, once the cirrhosis set in and you take an ERG, and if the ERG is flat and all, then actually there is no point in doing that. But the presence of the foreign body as such, it is going to be an issue, especially for the patient and all. So generally tell him about the prognosis. It's not going to improve his vision. But then the further progression can be prevented, I mean, even if there is some amount of vision left. But anyway, we generally end up taking out the foreign body.